Good afternoon, everybody. We're very thrilled today to host in the Department of Medicine grounds the Robert Myberg Endowed Lecture in Cardiovascular Medicine. We have Dr. Dangas, Professor Dangas from Mount Sinai, who will be introduced very shortly, a world-renowned interventional cardiologist. And he's going to talk about the latest in cardiovascular medicine. But I would like to take a moment here and say a couple of words about the esteemed Dr. Robert J. Myberg, who has been a legendary figure at the University of Miami. He started his training, his career in the Maryland area with his undergrad and medical school studies in Johns Hopkins and the University of Maryland. Then he moved, he stayed south. He did his cardiovascular medicine training in Emory and residency, of course, in Tulane. And then he escalated the academic ranks. He has been he joined the University of Miami as faculty in 1970 as assistant professor. By that time, the department was Department of Medicine and Physiology. And over the years, he escalated the ranks to full professor. He became probably the longest chief of cardiology in the history of cardiology in the US. I believe he has been chief for almost 40 years. He has been a real legendary figure in the field, primarily of electrophysiology, a real educator, a paradigm for the generations to come of how a clinician, a cardiologist, can become an educator, can become a top-class clinical doctor, a researcher. He has been a luminary paradigm for all of us. And to him today, we dedicate this lecture. And what better example, opportunity for us to have as a speaker for this endowed lecture than Dr. Dangas, Professor Dangas from Mount Sinai. And I would like to pass this now to our chief resident to introduce Dr. Dangas.
Hey, good afternoon, everybody. It is my pleasure to welcome Professor George Dangas, who is Professor of Medicine, Cardiology, and Surgery Vascular at the Icahn School of Medicine at Mount Sinai in New York. He's also the Director of the Cardiovascular Innovation at Mount Sinai Hospital, Chief of Cardiology, Director of Transcatheter Cardiovascular Therapeutics, Textbook Editor for Interventional Cardiology, Principle and Practice, Chair of the American Heart Association Invasive Cardiology Committee, President of the Society for Cardiovascular Angiography and Interventions, SCAI, from 2023 to 2024. Professor Dangas is a leading authority in the performance of minimally invasive heart disease and vascular interventions, such as stents, angioplasty, atherectomy, and heart valve repair and replacement with both established and novel techniques. After studies at the National Kapodistrian University of Athens, he served as medical officer for the Hellenic Navy, and trained at Medicine Brown University, Miriam Hospital, after which he completed a fellowship in cardiology and interventional cardiology at Mount Sinai. Among the 5 founding physicians of the Cardiovascular Research Foundation in New York City, he was a key faculty at Lenox Hill and Columbia University Medical Center and led the establishment of an interventional fellowship program at both locations. He served as trustee at ACC and SCAI, fellow of ESC and AHA, founder of ACC Interventional Council Section, cardiology chair at Onassis Heart Center, and chair of AHA Lainic Society. He's a master of ACC of SCAI, JAC section editor, 2019 ACC Distinguished Fellow, 2017 Teacher of the Year, and included in many super doctors and who is who lists over 10 years. Please help me in welcoming Professor George Dangas.
Well, many thanks, Dr. Regis, for this very extensive and kind introduction. And many thanks for Dr. Hadjizis for spearheading the invitation, along with Dr. O. Weiss, who I also thank for his long-term association and friendship. It's my pleasure to be considered for this named lecturership, as Dr. Robert Meyerberg was really truly a legend, not only in Miami and Florida, but all throughout the United States for his work in arrhythmia and sudden cardiac death. And of course, a legendary long-term leader in academic cardiology. So along these lines, I would like to start my lecture, which is going to be focused on the advances in cardiology, not the theoretical ones, but those that I view among the very many we had this past year, those that I view that may actually change practice and be notable from that point of view. And that encompasses a significant part of interventions, as I'm very close to my practice and interest, but at the same time, some aspects, very important aspects from imaging, as well as secondary prevention that impact the practice of everyone in the field. So intervention may be viewed as as an adversary to prevention, but no longer. For a long time and many years recently, the efforts to secondary prevention have been embedded to people's minds a little better when they are done or clearly spelled out at the time of a significant hospital procedure, such as PCI, of course, also a bypass or any other procedure, but PCI is perhaps, and a catheterization is perhaps a more common one. And then the full attention of all the referring doctors, family members, and the patient themselves is kind of very, very focused on what is to do and deliver in order to improve the situation from then on. One of the advances we understood this year is that coronary atherosclerosis imaging is not enough angiographically. And of course, in theory, many of us sort of knew that, and maybe anybody in this lecture has heard that. But under 5%, anything other than angiography was used for decades, has been used for decades in the United States. So it was sort of maybe a theoretical knowledge, or as we say, in one ear, out the other ear, for anyone who was practicing or kind of doing procedures, because they felt they sort of didn't need that. However, this particular year, in my view, was a year of the imaging, the last 12 or 15 months, because in a series of conferences, we had many keynote publications of all sorts of intravascular imaging techniques, optical coherence tomography, intravascular ultrasound, some other aspects of vulnerable plaque assessment and all that, the calcific plaque assessment, a plaque characterization assessments and all that. And in many New England Journal of Medicine level papers that we impacted guidelines recently, and will impact them again, in my view, in any update is coming up, it is indicated that in complex PCI, and most of the PCI we do these days, I must say, it's sort of complex because prevention has been so good. It is helped as far as outcomes of PCI with reduced MACE and other events of safety by the utilization of intravascular imaging. So that's now a realization. Hopefully it's going to not go out the other ear, but it's going to stay, particularly with the guidelines. We'll end up speaking with upcoming updates coming up real soon. Another aspect of PCI is, of course, patient selection. And one of the aspects we always had to discuss in patient selection was what is going on with the very elderly, coming up perhaps in the emergency room, through the emergency room, with maybe a limited MI. Senorita was a very interesting trial led in the United Kingdom by one of my associates in the Society of Cardiac Angiography and Intervention, Dr. Kunedian from Newcastle. And they found, they took patients with NSTEMI, so to speak, nothing to do with acute major MI, over 75 years of age. And, they indicated that perhaps an initially conservative management might be adequate in the 6-month follow-up. And indeed, except for a little bit of a better outcomes earlier, by a few months down the line, things seems to have equalized. So although perhaps there was some delayed PCI was utilized in a minority of the patients, overall, an initial conservative management for a limited NSTEMI could be very viable in the older population. I think that's an incredible and important message. And primarily, you can see that the cardiovascular death, or perhaps maybe the non-fatal MI, may have a trend, but other events were going the opposite way. You see the overall result was sort of neutral by the 6 months. Another aspect that we see a lot is what do we do with older patients with myocardial infarction that have multivessel disease? Are we dealing with a culprit only, or are we just going? The guidelines say for any myocardial infarction, maybe you have to do complete revascularization. Could that be the case even with the older population? And this older population on the FIRE trial, 75 plus age, a third of them had an STEMI, and 2/3 of them had a non-STEMI. You can see a significantly large trial, over 700 people per group. They did a culprit only or an FFR-based, physiology-based complete revascularization. That's, again, a strategy trial. That's why I think it's important for everyone, although it's an intervention in the core of it, but this is a strategy of how we really treat the patient. We saw right before, for small MI, maybe we go conservative initially in the older population. In the FIRE trial, looks like that the complete revascularization by FFR base, though, not only by angiography, seems to be the winner. So we have to do, again, a little bit more than angiography is, again, the message here. During PCI, utilizing the imaging in order to decide for PCI, the physiology or pathophysiology assessment by the fractional flow reserve, by the assessment of any culprit, only a culprit lesion or any ischemia producing lesion other than the culprit. Moving a little bit to TAVR, another important aspect, but not moving so much away from coronary disease. How do we deal with patients who have to have TAVR and have CAD, significant CAD? Are we doing PCI? The symptoms may just be more only from the aortic valve. Well, we don't do PCI. Well, maybe they need PCI later on, and then there is a valve cage in front of the coronaries. What's going on with that? That's another strategy trial. It's not a technique trial. And the notional 3 investigators published in high-end journal this year did a conservative management or PCI. So they examined that. Is it okay to do PCI or maybe sort of ignored? Interestingly, in a depth of 5 years, but also interestingly, within the first year, not much action, as you can see. The curves don't seem to separate until beyond the first year. So initially, it kind of doesn't matter, but in the end, it sort of matters. So better take care of the CAD at the time of PCI for the patient's longevity. And who knows, perhaps it's because a subsequent PCI was very difficult to perform through the cage or the valve. We didn't examine that very specifically, but in general, the message is long-term PCI beat conservative management in patients who require TAVR. So we have to take care of the PCI. And the benefit was a little bit through death, not so much, significantly for recurrent MI, and obviously as a subsequent of recurrent MI, there was a subsequent target vessel revascularization as well, so that you see where it came from, where the MACE difference came from. Well, enough said a little bit about PCI. The natural discussion here was, why do we bother so much about PCI? How about if you do surgery? How about if that strategy trial says, Does a severe AS and surgery. And severe CS and multivessel CAD. Why don't you send the patient for surgery? And that's something that I was actually thinking of saying like that. Just send the patient for surgery, 6 words. However, the only word that doesn't seem to be so easy to say anymore after this trial I'm going to present to you is the first word. It's a word just, because it's not a decision we make in a split second anymore. It's a decision we have to think twice or even 3 times about. In this trial, based primarily from Canada, expert system in all the Canadian hospitals, in a closed system, obviously, then PCI and CABG are not performed in any hospital. It's only the expert hospitals of Canada. We had FFR-guided PCI or all-time classic, CABG plus AVR by surgery in about 150, 164 patients per group here. And let's see what happens with the results of this study. The study was stopped by the DSMB because the decision was just not as expected. The splitting up early on, there was a staggering 23 versus 4% MACE difference, primarily spearheaded by an also staggering all-cause mortality difference of 13% versus 1%, nearly. And if you look even closer to the results, seems like aside from the expected, a few minor differences, maybe 5% people really require a repeat thoracotomy, and maybe a 13 or 15% of people had AFib. Quite frankly, that was much less than I would think. And those are expected. We had the unexpected findings of a major mortality and a trend towards a higher stroke with the weak trend, I would say, for stroke or TIA 1 versus 4% with the surgery. So, until you do the trial, nothing is as easy as we always thought. Just not an easy decision anymore. We have to all think about that. So let's move a little bit to the emergency room and emergency situations, leaving a little bit the elective CAD and elective PCI or maybe a surgery. Talk a little bit about the ventricular circulatory support. We had 2 very important studies. One study brings us essentially to the emergency cardiology, emergency room, ECLS shock. This is a trial, primarily European trial, few hundred patients, 200 per group, very large trial for this type of thing, very involving trial. One group had received ECMO, cardiac life support, immediately, and versus the control. So it's a lot of mobilization. If this study is positive, everybody's going to brush up on exactly how we're going to figure out our ECHO team or our ECMO team to show up on time 24/7, 365. Well, seems like the results didn't pan out as expected. The lines didn't budge at all. It looks like the control here is a winner. So avoiding a 24/7, 365 ECMO group on call right next to the emergency room seems to be prudent at this time. And we continue to go on with judicious utilization of mechanical circulatory support rather than the blanket all-comer suggestion, this trial study. Certainly, there were many centers in Europe that have to change their practice as this type of ER-level support with ECMO was would have some traction in several centers overseas, not so much in the United States, though. Coming also from Europe, the DANGER trial, well, it's not really meant to be danger, it's meant to be danger, the Danish-German shock trial. And finally, we have a positive trial in the area of mechanical circulatory support. This time, we're not talking about an outside the body pump like ECMO. We're talking about the macroaxial flow pump, which is inside, intra-arterial, through the arteries. One port is in the LV, the other port is ascending aorta. The blood is pumped from LV to aorta based on the Archimedes screw, little machine that's inside there. There was 180 patients ultimately per group. and the results indicating the 6-month time frame with initial trend, positive trend at 1 month, and definite significant, I should say, results at the 6 month. This 30-day and 6 months follow-up was selected to mimic the groundbreaking initial shock trial from the time I was a fellow. That indeed had that time the primary endpoint was at 30 days, was only a trend. The significant result had emerged for that at the 6 month for revascularization versus initial medical stabilization in that trial. In this trial, in this study of this year, the danger group reversed. The primary outcome was a successful one, the 6-month one. The trend was again repeated at 1 month. So it looks like the two studies are somewhat internally consistent. And now we know that a minimally invasive percutaneous microaxial flow pump can be of help in such patients, and obviously brushing up of how we can initiate a shock team successfully is becoming now a part of pretty much any cath lab these days. Definitely practice changing. Let's move now to broader horizons beyond PCI. Secondary prevention, and see how we can solidify. And this, I think, is not only PCI; it also can be any cardiovascular outcome, including perhaps a post-surgical outcome, or perhaps even how to intensify initial conservative management, but with milestones in the future. Antiplatelet therapy remains a cornerstone of combination of any combination therapy. That many drugs you have at different stages of adhesion, but mainly activation and aggregation is what we try to affect for the most part, and we use combination medical therapy for all aspects. And what we try to find is no longer a one-size-fits-all approach, because that doesn't exist. Patients are very different, and even the diseases changes a lot over time. In the graph I show you on the right side, you can see that the ischemic risk is front-loaded and is actually quite high the initial week and somewhat attenuated over the next few months. Nonetheless, at the very bottom, although there may be a procedural bleeding risk, the actual long-term bleeding risk, it is both persistent as well as long-term, and doesn't seem to attenuate at all below a certain baseline rate. So if you go on the left side graph, what everybody hopes and perhaps finds way to realize, as opposed to just fantasize, that all the patients belong in the sweet spot. How do we actually move around and reassess the bleeding and ischemic risk of a patient periodically at each time visit, as opposed to look at the cath report or the discharge summary or the post-surgical outcome, or and just identify a patient and some kind of a pigeonhole that this person was for long DAP, this patient was for short one, or I don't know what else. And what we've been doing over the years, recently, was to try to experiment in a way that we can subtract therapies, reduce therapies. Could we drop drugs? Could we even drop aspirin? Could we stop drugs? Should we reduce doses of drugs? We're really trying to target, after decades of trying to optimize to mitigate the ischemic risk, perhaps we reached the bottom of that in the long term. We're now targeting to also improve patient outcomes by mitigating the bleeding risk, minimizing the bleeding risk, even acknowledging it is a minor problem rather than just a medication side effect. One of the very first items that we studied in the Twilight study, in the first of a series of studies that actually we spearheaded here on Mount Sinai, and we're happy now to have it be a part of a over 20,000 patient meta-analysis on a similar subject with ticagrelor monotherapy after an abbreviated course of dual antiplatelet therapy seems to have yielding consistently a similar ischemic event but have a staggering decrease in significant bleeding complications, as you see at the bottom left, by about 50%. So that's a lot of comorbidity reduction by a rather simple measure, the drop the aspirin compared with ticagrelor monotherapy. And definitely the Lancet editorialists also agree with that. So we expect to see a lot of guideline updates in the United States. You can already see the 23 and 2024 European guidelines, just because the updates, I think, are just not timed at the same years. I'm sure we're going to have a similar moves in the United States, because the trials are the trials results. And you can see that the mandatory DAP, dual antiplatelet therapy, is no longer long, is actually short. So from then on, you have to continue to evaluate the ischemic risk and the bleeding risk of the patient. And you continue judiciously beyond the 1 month, perhaps to 3 or 6 months after a major MI with a lot of stents or a major surgery. But without, you may want to just de-escalate to a lower group, to a monotherapy with ticagrelor, as we said, or with clopidogrel in the lower risk patients. And definitely do not adhere mindlessly to a long-term, intense dual combination therapy, where that might be DAPT, or I'm not covering in this talk because it's not a 2024 advance, a combination between antithrombotic and antiplatelet. Perhaps we can come back to that during the discussion session. But what is next, though, beyond what else can we do? Or what has been done, and what have we been realizing this past year beyond angioplasty, stent, bypass, antithrombotics? What else is happening? Quite a few are happening. We understand that the cholesterol risk is quite significant. And although we thought high-intensity stattin was a winner, we suddenly realized that perhaps we can do more. Perhaps we realize also we have to do more if we consider that Lp(a) is also emerging as an important risk factor. How about inflammatory risk at the same time, particularly important with the glycemic risk? And now I hear emerging all over residual triglyceride risk. Essentially, we're talking about a residual metabolic risk that we need to optimize. We had groundbreaking trials along this direction, and I think change everybody's mind. Let's pay a little closer attention to something. So this is the first of all the recommendation of the guidelines. Keep going very, very low. And again, 2023, we're going to have a new LDL lipid lowering guidelines in the United States coming up again, but they keep pushing down the guidelines to under 25, under 55 target. And where is that coming from? First of all, it's coming from perhaps now we can achieve it. And PCSK9 inhibition, particularly with the once or twice a year agent, the mRNA, the agent that we see here, has been studied extensively. And this particular year, we had another aspect. Until now, we used to discharge our patients with statin or other effects and consider PCSK9 later on. Now, this study reminds me of a initial high-intensity statins era, because, again, way back then, we used to go slow, escalate the dose of statin and follow up until the studies came up and say, you know what, forget about that. You start with 80 milligrams of atorvastatin, or later on this became similar to 40 milligrams of rosuvastatin, I should say. And then if need be, you modify taking it down or in any other way. But in the initial part, remember, that was the high ischemic risk of the patients. You really need to give them maximum protection. So now, this study, the Victorian Initiate, indicates that the patient given the PCSK9 inhibitor immediately, early on, if they have an accelerated risk or it's a maximally tolerated statin, early on. You can see that, and at least they had some good results. And I'm not positioning this as a ready to go, but it's definitely ready to consider. and I'm sure the other agent as well, as the alirocumab, evolocumab, we're looking at something very similar. It had some results with the modification of the plaques. So the early, upon discharge, perhaps even, PCSK9 inhibition is coming up now into a major play. I don't know how feasible it is to change the practice, because that's also important. Another important factor is the pre-authorization to utilize for this medication, and I'm sure that's exactly in part where our mind has been, but I definitely have been thinking of using any of these agents much earlier than before, after this year. These are various studies as well that is going on around the same categories, but let's move on, as I promised you, to lipoprotein A. That was one, used to be very close to my heart, used to be one of my fellowship projects, to stain for lipoprotein A in atherectomy specimens after in the coronary disease. And we found out, I remember at the same time, at that time, we found out how ubiquitous this was. It was something that it was important, very interesting. Nobody really knew how to deal with that. Kind of is everywhere, but exactly we don't understand what it does. Well, a lot of research emerging this past year into fruition after long term of investigations in many aspects. Even now it's kind of pretty much everywhere. Now they're trying to explain even calcific aortic valve stenosis progression on Lp(a), but definitely PAD, CAD, heart failure, and ischemic stroke have been associated with elevated levels of Lp(a), and this has become a matter of interest because there are agents that finally can affect Lp(a). All these decades before, perhaps we weren't so much interested. Because what could we do about it? There were some reports that niaspan, extended release niacin, had something to do with that. But other than that, this was viewed essentially as some sort of a marker for the patient that we can't affect. And if we can't affect, most doctors weren't even checking. So as we stay tuned for additional studies coming up with small RNA antisense molecules that you can see here, and other therapies that I'm sure coming up next. So Lp(a) is becoming in fashion to be measured, to be followed, and hopefully to be affected as well. For the time being, whenever someone has extremely high Lp(a), I really want to drive the LDL way much down than anybody else. And let's advance to another aspect that we've been also talking for a long time, and this inflammation. Because inflammation has a lot to do with something we don't understand. And I think that's why it hasn't been acted upon. Is inflammation perhaps a metabolic disease? Is a metabolic phenomenon, perhaps not even a disease, a syndrome, a conundrum? Is a diabetes problem a sugar problem, or it's really an inflammation problem? Or maybe both. There are modifiable risk factors, which we know: diet, lifestyle, hyperlipidemia, smoking, hypertension. At the same time, CKD, a lot to do with hypertension, a lot to do with inflammation. And at the same time, genetic predisposition, age have also a lot to do with this, although we don't seem to be doing anything about those. For sure, a lot of things now coming up in our armamentarium. This year, we had a study that was a surprise study. It was a major study. In my mind, it worked, the results of it worked right straight to the heart of how important inflammation is and how important mitigation of inflammation is for what we do day in and day out. The select investigators led by the Cleveland Clinic in this particular paper investigated with an injectable semaglutide in any patient with obesity. Until just a year ago, this medication was for human use in patients with diabetes. So in brief, they use a diabetic medication for every with aim to improve cardiovascular disease if they are somewhat obese, which is a very good marker of having metabolic syndrome and high inflammatory status. This you see how it worked out, and the results were staggering. Without talking at all about weight or markers, talking just about MACE, you can see on the left side of the panel a clear win. MACE reduced by 20% over 4 years, and this effect seems to start early on, even before any measurable weight loss might have realized. So that's why I think that inflammation and obesity are entering a new era of therapies that will benefit cardiovascular disease. Another similar drug one can say it's oral, empagliflozin, SGLT2 inhibitor in acute myocardial infarction. Pretty straightforward. It's been very beneficial for CHF cases. In MI, on face value, sort of failed to meet the primary endpoint, but just a little bit. It was marginally beneficial, but it did again affirm that it did decrease the hospitalizations, for the most part, heart failure hospitalizations. So indeed, patients with large MI and heart failure, they're indicated for this. The types of new agents that, again, optimize the metabolic profile, and by that, improving the inflammatory profile of patients. It would be an omission to finish this talk with two very important trials about minor subjects. One can say minor academic subjects, but very important clinical subjects. One of them was, should we stop or continue beta blockers after a myocardial infarction? In my mind, why are we even studying it? I always keep my patient on low-dose beta blocker. Well, let's see how this pan out in the ABYSS investigators. Well, they studied 3,700 patients post-MI at least 6 months, and in patients who had at most mild LV dysfunction. So if someone had a moderate LV dysfunction, they would continue that. And the other continued or interrupted, and they assessed the MACE, and they plan to have a non-inferiority study at 1 year. And here's how it worked out. Failed. Non-inferiority failed, and we continue beta blockers. So I'm glad my practice is verified, and I do happily continue low-dose beta blockers. However, this may be revised because there's the many beta blocker naysayers, I think, are planning an additional study, this time with an absolutely normal LV function, and see if we can find different results in future years. But for now, no go for beta blocker stoppage. How about ACE inhibitors and ARBs pre-op, stop or not stop trial? Again, in my mind, what are we talking about? Ever since did we start this debate? Well, apparently I haven't been following closely the anesthesiology and the surgical, I would say, concerns regarding who knows what, hypotension, unfavorable surgical outcomes of all sorts of operations. Make the long story short, all these drugs were being stopped routinely by fear of severe hypotension or renal failure post-operative. Well, in this very interesting study of a very memorable 2,222 patients, I don't know if they planned it that way or they did it or did it happen like that, but it's definitely very, very newsworthy, as we say, this memorable number of patients, they discontinued the renal angiotensin system or they continued them very simply. And the results, identical number of events in both groups. 22% of patients had an event, as they call it, a mortality or major postoperative complication, including, of course, bleedings, reoperations, all sorts of other things. Overall, no go. Don't need to worry about stopping ACE or ARB. The particular aspect in selected patients with some kind of risks to kidneys or other aspects you specifically concern, perhaps you do it, but no more these blanket things and no more these last-minute calls. Oh, we have to postpone surgery because you guys in cardiology forgot to stop the ARB a week earlier. Thank you so much for your attention, and I look forward to a discussion, to a short discussion session, and I look forward also to see many of you next week at TCT or online at TCT, and even some of you next May in Washington, D.C. at the Society of Cardiovascular Angiography and Intervention sessions.
Thank you, Professor Dangas, for that scholarly and literally up-to-date, as recently as 2 weeks ago, articles. Really, really important information that you gave us. And I'm sure you read more than just the New England Journal of Medicine, and I'm sure the editors are very pleased with the number of papers that you were able to share with us today. So this is really exciting and interesting time in understanding treatment of our patients and how we might manage them. From the perspective of someone who is taking care of a patient in their office, who comes with social determinants of disease, who comes with certain backgrounds that may be Latin, African American, how do you customize your thinking about their lipid control, the totality of their cardiovascular health, in terms of trying to put together all these different studies that really are from maybe different populations from what your patient is in the hospital? How would you recommend that those of us in the clinic who are taking care of the one patient in front of us think about these studies?
This is a great question, because addresses number one, how do we deal with all this? There's just a list, a checklist of all these classes of medications, essentially. For CAD, maybe 6 classes. For CHF, maybe now 6 to 8 classes. And in every condition, so to speak, several ones. And at the same time, also touches on the fact of diversity aspects in clinical trial results. And how does this relate to the different populations? The second one I'll answer first is that everybody becomes progressively sensitive about it, and women and minorities are always focused on, and perhaps we should be routinely publishing in the appendix of the major study the subgroup analysis of those pertinent groups and allow data sharing, so broader databases of this diversity-oriented research can be accomplished. On the other hand, we also, in our clinic, we have to, I think, diversify our groups, because the people and the families react much better, in my view, the more open we are about the languages that we speak, about everybody welcoming in their own different ways. So then they can become more receptive to, number one, show up in follow-up, because that's a very simple thing, but that's one of the challenges we have. And of course, we're going to enter in this, would say, this titration of medications stepwise. So the people need to become very accustomed to our team. They need to like our team. They need to like our clinic. They're going to feel that we answer the question, we address the problem, we hear their concerns. We don't have to start all the medications at once, but we have to work with them and they have to work with us in order to make this happen. So the more we transmit that to them while waiting for the diversity trial results, I would say, the second part, the personal part, the human part, we can take care of that by building the right team around us.
Thank you. Dr. Hatzitsas, I see you unmuted yourself. Do you have a question?
Yes, absolutely. That was a phenomenal and very evidence presentation, Dr. Dangas, and we're very blessed to have access to this knowledge off the press, very, very fresh knowledge. My question would be a little bit of kind of like provocative here. From all this evidence that you showed, which is the latest at this point, according to your experience, your intuition, your gut feeling, which one you would feel that is the most groundbreaking? Where do you see the big change
Well,
happening?
I thought that the SELECT trial of the semaglutide, or using liberalizing the utilization of an agent that formerly was a parenteral anti-diabetic drug, into now coming into play as a major factor in optimizing obesity and metabolic profile, leading to a major decrease in cardiac events, is just, I think, a paradigm change. And whether that's going to be seconded or similarly followed by the SGLT2 inhibitors, or perhaps by oral GLP-1 agents, who knows? To be continued, but clearly that's a new chapter. I address also some other questions I see from the chat is somewhat related, that the inflammation otherwise, and there are only two drugs. One of them was a canakinumab that was very expensive and it just not pursued anymore. So that's out, despite the marginally positive study. And colchicine, which is rather inexpensive, but is a non-specific agent of inflammation mitigation. It's very useful, I would say, for recurrent or post-operative pericarditis and other things. For coronary disease, there are many studies, not very large ones, and not a lot of industry support in this field. And there's several consensus papers. One of those was ours a year ago. Now the database, the guidelines indicate its use, level 2, and again, it's viewed as, I would say, a mildly beneficial agent with a little bit of an unknown long-term or not such a long-term utilization for a chronic risk modification. So it's not at the level of an advancement of the SELECT trial that opens really a groundbreaking door.
Dr. Martinez, do you want to unmute yourself and ask your question?
Yes. Hi, thank you very much for this amazing update. I really enjoyed it. And my question was regarding, again, inflammation, and such an important topic, whether you use any special biomarkers to monitor your management to see if you're really making any difference in inflammation, and then, or any other additional modalities or suggestions, like alternative things.
Yeah, very,
Yes.
very good question. I think for several years, LPA and high sensitivity CRP were part of my initial patient profile, let's say. But over time, I do also follow the hsCRP periodically in order to see where we are, particularly if I notice a kind of a disconnect between that level and the lipid level. And in those cases, I specifically consider the colchicine, for example. I also I'm a little bit more liberal than average on the utilization of the BNP biomarkers, because I also do think that, although perhaps unrelated with inflammation themselves, they are a very useful indicator of cardiac versus non-cardiac shortness of breath. And even mild shortness of breath can emerge anytime, and it appears in our Epic chats or in our messages or phone call logs from patients all the time. And having a kind of baseline understanding every once in a while we're trying to review this patient complaints may happen at any time, it would be a good idea to kind of know where they are. So I do use that marker a little bit more than others, I would say. And regarding the LDL marker, I really would like to see that going below 50, particularly even perhaps low than 30, I must say, if we're dealing with someone with a very low HDL and a significant cardiac event. And without opening a can of worms, I must say that I belong also in the minority of doctors who are measuring the platelet reactivity units to determine or decipher if some of my patients are resistant or non-responder to clopidogrel, and how I can improve that at the time of a subsequent PCI, or very importantly, before referring them to any heart surgery when we stop it and all that.
Okay. Well, thank you very much, Professor Dangas. We're very grateful to have you here and welcome you in person to Miami, although the weather, as I understand it, in New York is probably Miami-like today. So thank you again. I remind everybody to look in the chat for the link for the CME and MOC credits. And I look forward to seeing everybody next week. Have a wonderful day and be safe. Thank you.
Thank you, Dr. Weiss. Thank you, everybody.